come in?
Hi.
Hi.
I'm student Dr. Waters.
Hi,
Nicole?
Yes, hi.
Nice to meet you.
Very nice to meet you.
Alright, so what brings you in today?
Well, I'm pregnant.
Congratulations.
Thank you. And so, the first thing I found out was I was pregnant. The second thing I found out is that I guess I'm old. I'm 38. And, I was doing this research and, on the internet and everything, and all I read was that, there are risks once you're over 35, and there's all kinds of things that you should be worried about, and I guess there's some things you can screen for and some things you can test for, and I don't really know what that means or what I should do, and so that's why I'm here, is to find out what I'm supposed to do.
Yeah, I mean, you go with something, you're like, oh, this is really scary, so, well, I mean, what you saw on the internet is partially true. As you get older, it does kind of increase your chances of having a baby that may have a genetic defect, but still, it's not super high like everyone. So what we can do, we can screen for different types of genetic defects, just certain ones. We can't screen for all of them, but there's the major ones that we can screen for, and they're usually tests that are done in the first trimester, so early on in pregnancy, and there's different types, so you can do a blood test to screen for certain things that might be in your blood that might be elevated or low, and that can give us kind of an idea of what your risk may be for the baby having a problem. And then they can also do an ultrasound, and that can kind of guide by measuring a part of the baby's neck during a certain time during pregnancy. They can use that to kind of guide also the risk of having a problem with the baby. So.
Is the ultrasound what you see on TV all the time, where they, you see the picture of the baby, they press it to the stomach? Yeah,
well, early on sometimes they do one where they actually do it through the vagina, so they have a little probe that they can do that way, and that gives a better picture. Or they can do it abdominally. It just kind of depends on when in pregnancy they do it, because it gives different views depending on how big the baby is, and then if some of these screening tests came back at an increased risk, then there's other more invasive tests they can do later on, where it's something called an amniocentesis, when they can put a big needle in and take a little bit of the amniotic fluid and analyze it that way and see what that shows, and things like that. So obviously all of these screening tests come with good ups and downs. They're not perfect. Some, they may give you a false positive or a false negative. It may not, which kind of just means they may, it might come back high and say, oh, you're at high risk, but in actuality, you're not, Does that make sense? I don't know.
So I guess
very well.
I think what you're saying is that if it comes back negative, I might think, well, that's negative forever, but it isn't necessarily.
But it may not. It doesn't necessarily mean that your baby is not going to have a problem, because we don't have any guarantees.
Sure.
So
I mean, is it better to have the test than not have it?
That's a really individualized decision, because every person. I mean, it kind of depends on what your idea is and what you and your husband talk about, whether or not, if it would change anything. Because for some people, they may want to know early, and they may want to terminate the pregnancy if the baby had a problem. But then some people would say, I would never do that, so I don't want to know. Or, I would want to know, but I would just want to be prepared in case, So it's a really individualized decision, I think.
So, like you said, there are risks for these tests. What's the worst thing that could happen if I got one of those?
With some of those early ones, there's not necessarily a risk to the baby. It's more just, like we were talking about, that it may come back positive or negative and then be wrong. And then the other test I was talking about, the amniocentesis, that does come with the risk of possibly causing preterm labor or a problem with the baby later on. So
does that happen a lot? Have you seen that?
I'm not sure. I haven't seen it, but I'm not sure how often that happens. I could check and find out. But
I I guess another question I have is one of the things that I was reading talking about, like trisomy, and I guess the most common birth defects that you could have, and like I kept seeing trisomy and numbers.
Right.
Can you tell me what those are?
Yeah, well, you've probably heard of Down syndrome, right?
Yes.
That's trisomy 21 is the term we use, and that just means that there's 3 copies of that chromosome 21.
Oh, okay.
And so then that results in children who have Down syndrome.
Oh, okay.
There's other ones like trisomy 18, trisomy 13, and those are just the same, like 3 copies of that chromosome, and it just causes a different presentation of problems. So
is it like Down syndrome then? They just have some.
It's pretty different. Those trisomy 18 and trisomy 13, they usually have more problems with their heart and problems with. They usually don't live very long. I can't remember the specifics, but I could get the information for you if you wanted to know more about those issues. So yeah. Okay. And then the other one is the neural tube defects. Like, have you heard of spina bifida and some of those conditions where the spinal cord doesn't form correctly? And so that can be tested for also with these tests, and kind of give you an idea if the baby has an issue with that. So,
okay.
Yeah.
It's just a lot of different things. I mean, if you were me, what would you do? Like, what do you think the best thing to do is?
That's really hard. It's kind of, I mean, as what I was saying earlier, everyone's different. So I think you have to talk about it with your husband and just see, is this going to change anything for us? Are we going to, is it going to affect how we live and what we do with this baby? And,
Okay. I mean, like, do you think, most people that get the tests are happy they got them? Do you ever meet people that didn't do any of the tests and they're like, oh, we wish we had, if only we'd known, whatever?
Yeah. I mean, I haven't personally talked to anyone who had issues with it, but I'm sure that it probably does happen. I don't know.
Okay.
So,
that's one other thing. I read about some kind of, it's like a free DNA test, but not free like cost, like free like floating around something. Do you know about that?
I don't know about that one. I would have to ask one of my attendants or something and get back to you about that.
I mean, I don't remember that much.
I don't know.
It was on the list of like all the different tests and things.
Right.
So,
yeah.
And what's the difference between like a screening and a testing? Because they kept using those words, but it didn't seem like they were talking about like two different things.
I don't think I explained that very well. So all these tests are screening tests, and that just gives us. Well, basically they'll take the results and they'll analyze them and then give us back a number and say, like, this person's at risk, like 1 out of 1,000 or something for having a child with this problem. So it doesn't diagnose and say, yes, this baby has an issue. It just says there's an increased risk.
Okay, right.
And then if you're testing for it, which I believe you can do with amniocentesis because it's more exact, but it may not be 100%. But if you're testing for something, that can usually diagnose it. But most of these are screening tests, so they just kind of give you a risk range.
Okay.
So.
Okay.
I hope that helped.
That does help. I think I'll just have to talk to my husband about it.
Yeah.
I think we definitely want to know, but I'm not sure. But that's helpful.
Okay.
So,
good.
Okay.
All right.
All right. Thank you. I appreciate it.
Thank you so much. good?
Yeah, that's okay. I'll edit it later. Hi, Julie. My name is Dr. Peterson.
Hi.
How are you?
Good.
How do you think things went?
They were okay, I guess.
I think you did a really good job, and this is never. It's not meant to be a test. It's just meant to help you kind of learn how to do this type of counseling so that you feel comfortable. And I think you did a really good job approaching the patient and had a really nice kind of bedside manner. A lot of the facts and things like that will come as you get further and further in your training. So you did a really good job. I'm just going to kind of go point by point, just to kind of highlight some things that we noticed when we were watching, and then at the end we have kind of a summary sheet for you to take, just so you kind of can start to incorporate some of this the next time you counsel a patient. So I think you did a good job starting off with how aneuploidy is related to age, in the sense that as we get older, the risk of having chromosomal rearrangements increases. And one way that I try to kind of help patients understand this is to try to divide out trisomy 13 and 18 and trisomy 21, because they're very different outcomes, and I think most patients have different reactions to both of those. So starting with 13 and 18, I think you did a really good job of describing that it was more severe than Down syndrome, more anomalies, and that these babies don't survive for very long. It varies. I mean, there are survivors that survive for 10, 12 years, but like you said, a lot of babies have fetal demise, a lot of babies die in the neonatal period. Sublethal is the medical term for it, but again, it's important for patients to understand that these are much more severe than Down syndrome, and that most babies die in the first year of life, but not all of them. When we talk about Down syndrome, most people know what Down syndrome is that have met or seen a person. But there's a huge spectrum in Down syndrome, meaning there are individuals with Down syndrome that have a fairly high IQ that can live independently and work, and then there are Down syndrome children and people that have a very low IQ that need assisted living and things like that. And there are medical problems that go along with it as well: heart defects, GI tract anomalies, early Alzheimer's, and a shortened lifespan. So these are all things that certainly we want to make sure patients understand, because trisomy 21 is a condition that might polarize people a little bit more one way or the other, whether they would continue or terminate. I think for trisomy 13 and 18, you could argue that more people might terminate for that, but 21 is one that it's more difficult because the outcomes can vary so much. But I think that's the way that I would recommend that you approach it. As far as talking about serum integrated screening, I think you did a good job of kind of describing that there are blood levels and hormones that we can do in the first and second trimester, and depending on where you work or what lab you use, they can be incorporated in different ways. And again, the specifics are not as important until you get to the place where you're going to work, and then you need to know kind of which test you use. But I think you did a good job kind of highlighting the fact that it was not a threat to the pregnancy, that it was screening, that there's false positive and false negative numbers, because it's important for a patient to understand that if they do the test, there's about a 5 to 8% chance of having a false positive. And the flip side, if the test is negative, that doesn't guarantee that the baby's normal. In fact, a pregnant mom can do every test that we have available and still have a baby with an anomaly. So I think you did a good job touching on that. One area for improvement, I think, would be about the way you talked about the use of ultrasound in the screening process. You did a good job describing the first trimester, nuchal translucency, could mention the nasal bone also. But the second trimester is a really valuable time to do ultrasound also, because you can take whatever screening the patient's decided to do and modify that with an ultrasound, where we look at the nuchal thickness, we look at the nasal bone, we look at the heart structure, the echogenicity of the bowel, whether there's a double bubble suggestive of duodenal atresia, kidney dilation, short and long bones, and other soft markers of Down syndrome. So for someone that's kind of on the fence about what to do, that can be kind of give us the final risk analysis. And I think you did a good job saying that, we can actually put a number to this. So we can tell you there's a 1 in 1,000 chance of Down syndrome, or there's a 1 in 200 chance of Down syndrome, because I think that's imperative for a patient to have a baseline understanding of how at risk, because when we talk about invasive testing, we talk about the rates of pregnancy loss with the test. So with CBS, or the first trimester version of an invasive test, the risk of pregnancy loss is about 1 in 200 compared to an amnio risk of about 1 in 300 to 500. So I think one thing you could do a little bit better is just to highlight that's the main thing that we worry about when we do this test, is causing a pregnancy loss. And again, if a patient has an idea based on either their age or their serum screening of how worried are we, it helps kind of them put those numbers on a balance to say, well, is it worth doing the amnio to know for sure? You did mention ONTDs, neural tube defects, and both serum screening and ultrasound are very effective at picking those two things up. The detection rate approaches 95 to 97%, so it's important to note that that's part of the screening process as well. The limitations of diagnostic testing, I think you touched on this also, that again, you can do all of these tests, but again, it's not a guarantee. And even with an amnio, it's not a guarantee that we're going to pick up rare genetic conditions, metabolic conditions, conditions like autism. So I think it's important that the patient understands that there's a limitation to the science that we have right now. But there are choices that put a pregnancy at risk that are diagnostic, that can tell us with almost 100% certainty, or there's a risk modification that we can do that doesn't put the pregnancy at any risk, but isn't 100% guarantee that the baby's normal. So you did a good job of you're kind of put on the spot of, well, what would you do or what should I do? And that's very common for patients to want you to tell them to do, but our job is really to educate, not to kind of direct them one way or the other. So I think you did a good job with that. She mentioned the option of free field DNA testing, and again, wouldn't expect you necessarily, right? And it's something that's just now coming about, and as time goes on, we're going to figure out how to use the test. It kind of falls somewhere in between a screening test and a diagnostic test, in the sense that it's still marketed as a screening test, regardless of which version of the test, but the sensitivity approaches 97-98%, so it's very close to a diagnostic test. But right now it's very, very expensive. We're still trying to figure out how to use it, but again, you may find more and more patients come in with questions about it because there's advertisements for it and things like that. And in closing, I think that one thing you did extraordinarily well was kind of the anticipatory guidance of, well, what would you do with this information? Some people would choose to do an earlier, I think you said some people would choose to do an earlier test so they'd have the option of termination. And you did that in a way that was very non-judgmental. And I think that's the most important concept in all of this, is that you never want your own personal feelings to guide what a patient chooses to do. And again, you presented it in a way that was very non-judgmental, in the sense that, you gave me the sense that regardless of what she chose, you were going to support her in that decision. I think that's a really important part of this counseling. So, do you have any questions about any of the parts of this scenario?
No, I think so.
Okay. And we'll give you just kind of a summary sheet of all the things that we talked about, just for you to review and to use the next time you counsel these patients. So, really good job.
Cool.
All right.
Thank you.
All right. Thanks.